In many communities across Kenya, mental illness remains misunderstood, hidden, and deeply stigmatized. For thousands of families, it is a silent struggle, one fought not only against illness but also against poverty, isolation, and discrimination. Yet here in Nyahururu, a community-driven movement is working to change this reality. St. Martin CSA runs 5 community-driven programs across 6 thematic areas: children's rights, peace and reconciliation, gender equality, sustainable livelihoods, youth empowerment, and mental health.
The story of St. Martin being born in Nyahururu is an interesting story. And it forms the foundation of everything we do, how we work. It is a story that was born out of an ordinary experience of a Catholic priest about 27, 28 years ago. There was a young Italian Catholic priest who was in this diocese, and he was out doing his priestly duties. He had been invited by a family to bless a home. And so in the process of blessing the home, he had access to every part of that home. So he went to the kitchen, he went to the bedroom, he went to all rooms practically, except one room that wasn't open. So he heard some noise behind that room. He opened that door, and what he found there changed his life forever. He encountered a young man who was seated on his dirt. He couldn't speak. He says he looked like somebody who had never even seen the sun, so he was white because of lack of exposure to sunlight. And so when he had an engagement with the mother of this young man, he discovered that the young man was actually his age. He was over 30 years of age, about 34 to be precise. And he was very touched by the difference, because he was 34, born and bred in Italy, had the opportunity to be in the seminary, sent to Africa as a missionary, had been to this guy's home, had been to their village. This guy had been there all this time. He had never seen his immediate surrounding. People didn't even know about his existence. So he came back to the parish asking himself, why the difference? Why such a huge difference, And so he started by involving the parishioners here at the cathedral, telling them what he encountered, and asking them just to go around and to see if there are other people. Later, the young man was baptized as Thomas. So he asked them to go around to see if there could be other Thomases locked behind doors, and then in 2-3 weeks' time, they discovered over 1,000 persons with disabilities who are locked behind doors. And from that encounter, he felt so much indebted to do something, to just go out there with the help of volunteers to talk about the existence of people with disabilities and to ask people to give them an opportunity to just experience life, go to church. And so from that very simple, ordinary encounter of a priest just doing his stuff, St. Martin was born. St. Martin Catholic Social Apostolate has a very unique mission in this community of Nyahururu, in the areas where we work. And our main mission is telling stories of people, telling the sufferings of people, and inviting the community, inviting their neighbors to participate in responding to those needs, to responding to the cry. So whenever we get to hear of somebody who is going through stuff in life, our immediate reaction is to make the neighbors know, make them aware, and invite them to participate in lightening that burden, or whatever it is that is in their life.
Through the Community Program for Mental Health, St. Martin CSA has spent years working alongside families, health professionals, and community leaders to ensure that people living with mental illness are not forgotten.
This program had its roots in the HIV program, where addiction was part of this project. This was because there was a relationship between HIV infections and also HIV-related deaths out of addiction. Addiction or alcohol use contributed to HIV infections because when people are intoxicated, they are more likely to get into risky behaviors. And when people are already in alcohol use, they were more likely to default on the use of HIV management drugs. So that was the relationship. In the year 2010, this relationship had become so obvious, and therefore there was need to act. And that is the time we designed the first project on addiction. And we rolled it out in 2012, not only targeting people who are HIV positive, but the general community as a way of prevention and also as a way of reducing HIV infection.
The program began in 1999 as a response to the devastating HIV and AIDS pandemic. As the program expanded, another crisis became visible, like alcohol and drug abuse.
Addiction, first of all, is a mental health issue. It's a disease. It's a chronic disease that is treated as a mental health illness. And besides that, we have people who have addiction, strictly speaking, but they also have what we call co-occurring conditions. That means they have addiction, but they also have other conditions that are purely of mental health nature. We have diseases that are impacted by addiction, and we have diseases that are also impacted by mental health.
In 2016, a community mental health assessment confirmed what many already suspected. There was high prevalence of mental illness, limited access to treatment, deep stigma, and low mental health awareness. Mental health was not only a health issue, it was a community crisis.
Our approach, or the community program for mental health approach, is very unique because it is community-based and it is participatory. We don't just look at the client as one person. We look at the client in terms of being a member of the community, being a member of the family, and so we involve a set of community volunteers who are trained to identify these people in the community and also to refer them for medical care. And so for us, our approach is multidimensional. We don't just work in isolation, but we incorporate the community and also the government facilities. So the Community Program for Mental Health of St. Martin is a program that is designed to support persons living with mental illness in the community and those that are recovering from drug addiction. Because for us, support is very important for these people. Because in the community, there is a lot of stigma, there is a lot of misinformation about mental health. And so we become the people who listen without judging. We become the hand that support those people with mental illness in the community so that they can be able to recover holistically.
Today, the Community Program for Mental Health provides integrated support addressing medical, psychosocial, and socio-economic needs. There are counseling sessions, medication support, community outreach, and home visits.
With home visits, we usually visit clients who I need to do screening, assessment. Those are the new clients who has been identified by the area volunteers. Family home visits are important because you empower them so that they can get understanding on the illness, how they can cope, how they can do away with the stigma and discrimination. And in a nutshell, we are able to support them in various areas. The families have transformed in a very powerful way because from lack of understanding, they now can understand the situation. They are there to medication and the clinics. They are able to reintegrate the people living with the mental illness in the community. And also, generally, there are some positive aspects that we see in the family, with the family members, and also the entire family system.
For one family, the journey through mental illness changed everything.
Life yangu ilikuwa mbaya sana, kwa sababu ilifika mahali hata stoki. Ilikuwa inafika ninafunga huyu makamba, inafika mahali ninafunga huyu makamba, kwa sababu ilikuwa station kali sana. Ukiwashilia huyu hata ikiwa ni kama dakika 10, hawezi fika pale, unasikia nduru imepigwa, amekuwa na conversion, ameanguka. Wakati mwingine kama si conversion, anatembea, unasikia nimeitiwa huko. Saa ingine hata ametoa nguo zote, amekaa ushi vile alizaliwa. Hali ikawa ngumu, ikafika mahali ya huyu tena ikawa kali. Ikawa sasa tunamfungia kwa hii room, sisi tunalala hii juu sasa ni vita. Ukimwambia lala inakuwa ni shida.
Baba Maria was once the sole provider for his family of 8.
Wakati huo, kuna watu walikuwa type 2. Kuna watu walikuwa na huruma, walikuwa wanatusaidia. Na kuna watu walikuwa naongea mambo ya uchungu sana. Unasikia hata ukiambiwa wewe ndio unajua chanzo ya kihini haya maneno. Sasa wanaanza kukukejeli, uko na machungu na wanazidi kukukejeli. Wengine hata wanauliza mfukuzeni.
The trauma extended beyond one person.
Kitambo wakati tulikuanga chini, kabla wa St. Martin wajitusaidia, tulikuwa tuna struggle na madhi. Tusaidia Maria na baba na watu wengine. Sio walikuja wakatusaidia sana. Wakasaidia baba madawa na Maria. Na wakanisomesha na nika change.
During home visits or during the trainings, we encourage them and we show them the importance of medication. We train and do a lot of education to the caregivers so that they may be able to give the medication as required.
Today, Baba Maria is stable and no longer violent.
Tumeona mafanikio makubwa sana. Sana. Kama sasa ni hawa, mimi ninaweza toka na nikuja hata jioni. Na ninakuta watu ambao hata wanajua nilienda kutafuta. Na hata kama sasa ni huyu Joseph Baba Maria, unaona ako na ile fadhili ya mwanadamu, utu ya mwanadamu, yani kukujali. Unasikia tu hata ukiketi hata anaambia watoto simuondokea mama yenu, mnaona vile amechoka. Sasa unaona anaenda fahamu imerudi.
Nimeona mabadiliko kubwa. Jadi madawa hadi wanaenda wakichange, wanaenda wakipona. Siku hizi wako sawa kabisa, kila kitu hadi unapata amefanya kazi ya home. Hadi mzee alikuwa amelimanga ishamba.
Addiction and mental health are often deeply connected.
The Intensive Outpatient Rehabilitation Program, which we call here IOP, is a program that is tailored to support people in addiction. And the way it works is such that people are either referred from the community or we go to the community ourselves and speak to persons suffering from addiction. We do screening and assessment, and those are two terms that we use. Screening is first of all to check whether indeed they have a problem with addiction, and then we assess to what level. Once we are satisfied that they fit in a level, we use a tool called the ASAM criteria, American Society of Addiction Medicine, and it has 5 levels. Once they fit at level 2 or level 3, that is according to the ASAM criteria, we admit them into the program. And then they go through a 13 weeks rehabilitation program. During those 13 weeks, we apply the AA 12 steps, the Alcoholics Anonymous 12 steps. That is what we use here. It is a series of therapies that we apply throughout the 12 steps and over the 13 weeks. Then we support them individually during the 13 weeks. There are individual sessions, but we also have group sessions where we speak with them in the plenary, because addiction, it doesn't matter whether you are abusing cannabis, for example, or alcohol, or what they call Chavez these days. Addiction is addiction.
Mimi, my drug of choice ilikuwa alcohol. Na pombe, unajua mtu huanza tu pole pole. Though nilikuja kulearn after kuingia kwa program, ndio sasa nikajua ilikuwa ugonjwa. So, mimi nikianza kukunywa pombe, hata sikuwa na shida. Nilikuwa tu nakunywa time nataka tu. By the way, for the first 3 years, nilikunywa 3 times. Just Christmas Eve, date 24 only, usiku nilikuwa tu nakunywa hiyo siku. Alafu sasa ikawa, nikaanza holidays, public holidays. I remember those times there were many holidays. Moi Day, Madaraka, Kenyatta Day. Alafu sasa nikaingia kwa weekend. Sunday, every Sunday. Paka sasa ikaingia Saturdays. Lakini sasa vile ilienda ikaingia each and every day. Alafu tena ikaingia kwa lazima ningeamkia asubuhi. Hapo sasa hata ndio siwezi kumbuka. Juu sasa ilianza ni kama iliniforce. Sasa sio wewe utasema. Sasa ile utanikunywa. Sasa ni mimi nitasema. Sasa kutoka hapo, I think sasa ni kitu after 80 years. Nikaingia sasa kwa ile sasa hatari. Singefanya anything kama sijakunywa. Asubuhi, yani maisha yangu sasa ilikuwa ni pombe. Nikikosa kukunywa, hata ukipita hapa hivi unge notice. Nilikuwa na shake mikono, yani mikono natetemeka. Na ukumbuke hii kazi yangu, nahitaji ushike brush na ukue makini. So hakuna kazi ningefanya kama sijakunywa. Asubuhi kuamka ilikuwa shida. Nasikia kichwa inakaa kama debe yenye imejaa maji. Unajaribu kuinua hii. Lakini sasa nikaendelea na hiyo, nikaendelea kukunywa mpaka ikafikia pahali I lost hope completely. Nika lose hope in such a way. Sasa nilikuwa nakunywa, sasa nilikuwa nataka nikunywe zaidi ndio nikufe. Effects zilikuwa mingi sana. Juu hata sio kwa familia tu. Mnakosana na bibi, mtoto anaona tu, unaona hata mtoto kama ni mtoto akishafika 7 years, kuna vitu huwa ana notice. Sasa kama saa hiyo silali kwa home, si atauliza mama yake kwenye niko. Mama yake si anajua tu ni ulevi, atamwambia namna gani. Yani inaenda tu ikimaliza relationship hata kwa family members. I remember hata wakati nilikuwa home, my other siblings hata walikuwa wanaambia madhe, huyu anafanya nini huko anakusumbua. Kama ni kitu ikifanyika home, it would take time for me to come and realize that something had happened at home, kwa sababu most of the time I'm drunk. Hata saa ile niko home bado mimi ni mlevi. Yani ni kama time siku wa mlevi ni saa ile nimelala. Kazi yangu ikaharibika kabisa. Kuna mambo mingi, lakini kuna pahali ilifika nikaona sasa hapana. Najaribu kukufa sikufi. Sasa mimi ilifika pahali nikaona hapana. Hii maisha sasa sio yangu. Acha sasa niamue. na vile nilikuwa nimejaribu kivyangu kuacha, kuna wakati nilikuwa najaribu kuacha na shindwa. Nikaona afadhali sasa I need help. I have to be helped to overcome this. Nilienda St. Martin. Sasa safari yangu ilianza hapo. St. Martin juu nao huwa wanashughulika na hiyo mambo. Wakanikujia wakaniambia hii mambo sasa sio mzuri. Na mimi sasa nikakubali, nikajoin program. 13 weeks nikakuwa equipped na recovery program.
Recovery is not an individual journey. It is a community effort.
I usually see changes when we really talk about self-awareness. And the client comes to terms and owns. You see, when you own something, you accept what you're going through, you know yourself, because sometimes people, especially the clients that we have, they don't have somebody to share with. And sometimes there is the stigma. You just think that somebody else is not going through what you are going through. But out of listening, out of not judging, out of loving, they open up and they come out well, and the healing process starts. The most important thing first ni kujijua, because where people feel they don't want to accept themselves, or even they don't know. So out of accepting oneself, that is one step forward. And then from then on, we know whatever issues you are going through, we know where are they coming from and why. Yeah. Then out of reviewing all that, then we're able to see a lot of change.
In the IOP, it is very, very crucial because it is the backbone of the program, of the IOP program. In that, one, we do the orientation, which is basically, the orientation is basically on matters knowing about drug addiction, and maybe how life has been to these clients because of drug addiction, orientation, and basically on how the program would be once the clients have been assessed and enrolled. Then, as I have another role, very important role, as to take them through the process of rehabilitation, where we do what we call the 12-step program. It is an extensive and exhaustive program, whereby we encourage the clients to acknowledge their weaknesses, to acknowledge their strength, and also to acknowledge that they can do better without drugs. Then another role basically is on family therapy, very, very importantly, because it is a component. And we normally take the clients with the family. We take them through the process of family therapy, because we cannot treat one and leave the other.
Over the past years, the program has expanded its reach across Laikipia and Nyahururu counties. The program has reached over 300,000 people through churches, youths, barazas, and schools. 3,000 clients have been supported, including people living with mental illness, individuals receiving counseling services, and those enrolled in intensive outpatient program recovery pathways.
Another success story is that we support the persons living with mental illness and even those recovering from drug addiction to enroll and to pay for the Social Health Authority premiums, annual premiums. So we support them because we feel that that is a very efficient way of support, of financial support, because every month they go for clinics and some of them are even admitted to the hospital for inpatient treatment. And so this supports them and it relieves the burden, the financial burden in the family. And for us, that is very important. We pay on average of 5,200 shillings per client.
559 community health promoters have been trained, 204 mental health champions have been equipped with advocacy and referral skills, 1,000 caregivers have been trained, 403 high school teachers and 133 deputy principals have been trained to strengthen school-based mental health support systems. 17 schools have established peer support clubs, fostering safe spaces for learners.
Rĩrĩa ndona andũ mena mũrwaru wa mental health, nĩngeragia mũno gũcera mũciĩ ũcio na gũtuma ndũgũ nao, nĩgetha ndĩmonererie mental health nĩ honagwo na makiria kumwatwarira St Martin nao makamatwara thibitari. Ngeragia muno gutuma andu na muciĩ ũcio nigetha tuteithie mũrwaru ũcio. Na nĩ ngoretwo ngĩtungata andũ aingĩ a mental health. Nginya ngaiga ũmwe thĩinĩ wa muciĩ wakwa. Uthiaga akorũra kũrĩa guothe orũra. Agacoka gũkũ, ngamũhe irio, agakoma, akaroka agathiĩ. Na nĩ ngenagĩra wĩra ũcio ndutaga wa mental health. Nĩ tondũ nĩ ndeithĩtie andũ aingĩ kũhĩtũkĩra St Martin kuma rĩrĩa yambĩrĩirie. Nĩ ngeragia gũcokanĩrĩria ikundi cia atumia kanitha-inĩ, na nĩ ngeragia gũcokereria na kwĩra andũ mental health nĩ honagwo. Na mũndũ aigua mũndũ ũrehingĩra nyũmba kana mũndũ ũrauga nĩ ekwĩyũraga, tukageria mũndũ ũcio tukamũthara na ihenya ndakeyũrage, na mũrimũ wa mental health nĩ ũhonagwo. Especially mental health kuma St Martin yoka nĩ tũtwarĩte andũ aingĩ na makahona.
When you think about mental health, one, should be everyone's responsibility. It's everyone's business. Yes, because one, there's no health without mental health. And if the government is keen on ensuring the good health of its populace, I think it's just important that they first seek to improve the mental health of the population. I will just give a short example that patients with chronic illnesses like cancer, hypertension, TB, mental health is a very important aspect of their care, even HIV. So if you're going to divorce mental health from primary mainstream healthcare, then I think we'll miss a very pivotal thing about mental health. The government also needs to realize that other than mental health affecting health, it also affects all aspects of our lives as the citizens, our social life, our career life, and everything. And so there's so many lost productive hours that go unutilized because of one or two reasons as related to mental health.
Despite the progress, mental health services remain severely under-resourced.
What more can be done in the field of mental health? Number one is prioritization of mental health, because that is actually the key thing. Prioritization of mental health in terms of funding, that is increase in funding of mental health activities, and also increase in funding will also lead to availability of psychiatric medication in the general hospital, because we know that psychiatric medication is very expensive. And so if it is available in the general hospital, then clients will be able to access these services. The other thing that needs to be done is the integration of mental health in primary health care. It is something that has been discussed, it is in the mental health policy, but it has not been implemented locally. And so for me, if that was to be done, then it means that mental health will be discussed in all tables. The Community Program for Mental Health Strategic Plan of 2022 to 2026 majorly focused on improvement of lives of persons living with mental illness, and not just improvement of life, holistic improvement. And that was to be done through the strengthening of communities' capacity to support persons living with mental illness, because we were seeing it as a ripple effect, that when we train a community member, then that effect goes to the client. And so we know that with the right support, persons living with mental illness can recover holistically.
Today, I would say that to be able to address mental health issues, there is need to work in partnership. It cannot be just government's issue alone, you know. The government, of course, has a bigger role. County government has a bigger role to respond to the needs because it's a devolved function. But even the community have a responsibility to partner with the government to do something. And so today we are lucky to have a memorandum of understanding with the county government of Laikipia. And one of the thematic areas where we support each other is mental health. In charity, not only mental health, because we have many organizations who are doing different things. It would be nice where we are today, because also resources are limited, that partners could specialize in different aspects, you know, so that we say our our gifting is in awareness raising, and you can just focus on that, you know. Our gifting is in running rehabilitation programs, and you can focus on that so that we can be able to synergize. Not everybody doing everything, you know. I think now is the 5th or the 6th year. We have consistently, through the mental health fundraiser, we have consistently involved the community in raising funds to be able to serve the people. I wish we could have a structure which is starting to develop. By the way, our mental health fundraiser is run by volunteers, about 100 people from the Nyahururu community who meet every year to plan this. So that even if, for whatever reason, God forbid, St. Martin stopped to be, then the issues of mental health could still be addressed by this team. So I hope and pray that over the years, the people we have involved could take up the responsibility, continue to serve their people very independently. Hopefully, as we go into the future, we're also trying to partner with the different structures that exist, so that whatever programs that we run could be mainstreamed in structures that can live even longer than St. Martin, so that the needs of the people can constantly be addressed, you know. Work with the county government, work with other organizations, work with community structures, so that they can enter into the spirit of addressing the needs of their people through the community volunteers whom we work with, who have been trained, that they can also continue to identify those needs, refer people to the right places without necessarily the intervention of the organization.
Since 2019, the initiative has mobilized nearly 17 million shillings to support treatment, rehabilitation, and community care. But the need continues to grow. Mental illness is treatable. Recovery is possible. But no one should have to walk that journey alone.
One thing that I would like for the world to know about mental health is that behind every mental health challenge is a person with dreams and hope, waiting for somebody to support them. And to know that recovery is possible for persons living with mental illness, and with the right support, these people can recover holistically.
There is no health without mental health. Mental health is key.
Ningemwambia mama mwenye ako na familia, wenye wako na hali changamoto kama hii, hiyo ni kitu ya kuisha, na baadaye maisha yatakuwa sawa, muradi tu mtu akae katika njia inayofaa.
Shida inanga mizizi na watakuja kupona.
St. Martin CSA are calling on government, development partners, corporate leaders, and communities to join this movement. Together, we can build a future where mental health services are accessible, stigma is eliminated, and every person living with mental illness is treated with dignity.